Today I'm going to talk about SBRT treatment planning, some practical considerations. I have no conflicts of interest to disclose. First, we are going to go through the basic principles of SBRT treatment planning. We are going to explain what's the difference between conventional fractionated plan versus SBRT plan. And I'm mainly going to focus on how to evaluate SBRT plan. And I'm going to use some examples such as spine, lung, or liver case. And also, we are going to discuss practical considerations for SBRT implementation. Stereotactic body radiotherapy, SBRT, has fractional dose larger or equal to 5 gray. It has a bigger range. It can be as low as 5 gray, sometimes to as high as 34 gray, I've seen, per fraction. The number of fraction is less or equal to 5. The range also could be 1 fraction only or up to 5 fraction. So safe delivery is of utmost importance due to the high fractional dose and small number of fractions. So at our institution, we started first SBRT spine case in January 2008. Then a couple months later, we implemented the SBRT lung, and later on liver. So we since have 2 new SBRT cases weekly, mostly the spine case. And we use variant trilogy or TrueBeam to deliver SBRT, and our treatment planning system is Eclipse. So here is a list of the current SBRT registry at our institution. We have a spine protocol, lung protocol, liver protocol, and I'm going to go through some of the examples in my talk. So all these protocols are based on the RTOG SBRT protocols, specifically RTOG 0631, the spine, 0813 and 0915, the lung protocol, and 0438, liver protocol. And these protocols actually specify very detailed requirements for treatment planning in terms of dose prescription, target coverage, and dose constraints. So we find that these protocols are very useful for our clinic, the implementation. So the basic, we have the goal of SBRT treatment plan is to ablate tissues within the PTV for most of the SBRT cases, the lung, liver, and spine cases. These tissues we assume inside the PTV were not considered at risk for complications. So dose inhomogeneity inside the PTV was considered acceptable, actually potentially advantageous, and not considered a priority in plan design. So maximum dose, point dose up to 160% of prescription dose is very common for SBRT plans. So the main objective of the plan usually is to minimize the volume of those normal tissues outside the PTV receiving high dose per fraction. Because a 50% prescription dose is for a 20 gray times 3 lung protocol is 10 gray. That's a very high dose. So you want to minimize those covering the normal tissue outside PTV. Of course, you also have to meet lots of constraints for those limiting organs. So let's go through an example. So if you have a beam margin very close to the beam penumbra you use, say usually, suppose you use a 5 or 6 millimeter margin around this PTV, your plan will have a very homogeneous PTV dose throughout. You'll have a maximum maybe point dose inside the PTV, maybe less than or close to 110%. But those fall off outside the PTV will be very slow. So the 50% volume of the prescription dose will cover a lot of tissues outside the PTV. So if the beam margin is much less than the beam penumbra, say usually can do 0 or up to 2 millimeter margin, the result of the distribution will be you have a very inhomogeneous PTV dose. The maximum dose will be, say, close to 125% or more of the prescription dose. Then the dose fall off will be very fast outside the PTV. So let me go through, review an example for cranial SIS planning. So in cranial SIS plan, we know the homogeneity index, the ratio of maximum PTV dose to the prescription dose, increases as beam margin decreases. So if you have the beam margin get closer to 0 or 1 millimeter, you will have very inhomogeneous dose inside the PTV. So for example, if you have a 4 millimeter margin, your maximum PTV dose probably will be under 1.2 or 120%. But if you as the homogeneity index decrease below 1.2, say suppose you have 1.2 and you have less, the normal tissue volume receiving 50% of the PTV will receiving 50% of prescription dose will increase sharply. So that's why cranial SIS plan, if you use linear, usually you have close to 125% or more maximum PTV dose. So for conventional fractionated plan, there's a fundamental difference. Should be fundamentally different from the SBRT plan. So this one, for prescription dose, conventional fractionated is 3 gray or less per fraction. SBRT is 5 gray or more, and very often it's very high, like 20 gray or more for lung case sometimes. Number of fractions, 10 or more for the conventional fraction, and SBRT is 5 or less. So the dose distribution inside PTV for conventional fractionated case usually is homogeneous, and maximum PTV dose usually is close to 110%. But for SBRT plan, it's very heterogeneous, and maximum PTV dose up to 160% is not uncommon. The dose gradient outside usually is very shallow or slow, and the SBRT plan is very steep. So let me just give another example to drive home the message, the difference. A 20 gray times 3 plan is totally different from a 2 gray times 30 plan. So use a very small lung lesion as an example. The PTV volume is only 33 cc. So SBRT plan, usually you have multiple non-coplanar beams, say for example 11, the beam margin 1. So you can see usually the maximum PTV dose, you can get more than 120%. And these are the volume receiving prescription dose, the volume receiving 50% prescription dose, and the volume receiving 25% prescription dose. But we have to remember 50% of prescription dose for a 20 gray per fraction plan is 10 gray. On the other hand, let's say I use the same beam arrangement, okay, but the beam margin I use 5 millimeter. For a 2 gray plan, you'll find, okay, the maximum dose is around 110. The volume receiving prescription dose will be 5.7 cc more than the SBRT plan. And the volume receiving 50% of prescription dose will be 66 cc more than this plan. And the V25 will be 169 cc more. But this one, 50% prescription dose is only 1 gray. Of course, normally people, when you do a 2 gray per fraction plan, you don't really need to use 11 beams for such a small lesion. So then you say, oh, three field should be enough. Then same beam margin, if you use 3 field, okay, the volume receiving prescription dose will be even much more than this number, okay? 271 cc more than the V50 for SBRT plan. So if you use your normal way to plan for a conventional fractionated plan and try to apply to a SBRT plan, you can see how many more normal tissue will receiving very high dose per fraction. So for SBRT plan, the prescription isodose level is usually not 100% prescription dose covering 100% PTV. Usually it's often 95% prescription dose covering 95% of PTV or higher, or 100% prescription dose covering 95% PTV or higher. This coverage was chosen because of the increased tissue volume that must be irradiated to cover the corners of the PTV, every little corner. So suppose you're attending, did a little bit of hand shaking, started squeeze a little bit points more outside. So then if you want to cover everything, then your coverage to the normal tissue volume will be increased dramatically. So for conventional fractionated plans, you tend to have much better, like say, often you can do 100% prescription dose to cover 100 PTV. So SBRT planning principles are very similar to the cranial SIS planning principles. Basically, you have to have inhomogeneous dose inside the PTV to achieve sharp dose fall off outside PTV. And you have to, most of the time, or very often, use multiple non-coplanar beams or ARCs to create a conformal dose distributions. Actually, in some ways, SBRT plan is more complex than SIS plan for linear-based system because you have much more limited clearance for non-coplanar beams. So this protocol, these two protocols, RTOG 0813 and 0915 for the long protocols, specify very clearly the requirements for SBRT plan. So let me go through a couple of these important points. The maximum dose, if you normalize to be 100%, must be within PTV. Prescription isodose line must be between 60% or to 90%. That means if you normalize 100% as a prescription dose, the maximum prescription PTV dose should be beyond the 110% and under 167%. And prescription isodose surface coverage, they require the prescription dose cover PTV at least 95%. And also the 90% of prescription dose cover at least 99% of PTV. And there's a requirement for high dose split. The cumulative volume of all tissues outside the PTV receiving a dose of more than 105% of prescription should be no more than 15% of the PTV volume. So your 105 hotspots should be mostly within the PTV. And there's, most importantly, intermediate dose split requirements. So the fall-off gradient beyond the PTV extending into normal tissue structures must be rapid in all directions and meet the criteria in the table 1. Of course, you have lots of these other limiting constraints like cord, kidney, all these other ribs. So this table, the so-called intermediate dose fall-off table, is very important. This is actually treatment planning part most difficult to meet. So there are a couple of important items here. According to the PTV, depend on your PTV volume, the ratio of prescription isodose volume to the PTV, usually defined as conformity index, should be less than 1.2. The ratio of 50% of prescription isodose volume to the PTV volume, that's R50, should be, but depending on your volume size, between the less than these numbers. And the maximum dose in percentage of dose prescribed at 2 cm from the PTV in any direction, this is called D2cm, should be under this number if you don't have any violation. So depending on your volume, these are the requirements. And this so-called percent of lung receiving 20 gray, those are the least problem of your treatment planning, because the tumor usually are small. You don't have any problem meet the lung constraints. So at our institution, okay, the published protocols at this point usually do not specify R50 or D2cm requirements for spine and liver cases, because they only specify very clearly in the lung protocol. Nevertheless, we find the lung protocol criteria used for spine and liver cases are very useful for our planning in spine and liver cases. So at this point, our institution, the planner, when they do a plan for spine or liver, they will put up those two, they will put up this table plus this requirement to make sure our plan meets these. And we usually have no problem meet. So let me just go through some of the examples. For example, the SBRT lung, we have a regimen for single fraction 16 gray according to RTOG 0631. These we done for cases we have confidence in the setup. For example, inferior T-spine and L-spine lesions. And we have also another 3-fraction approach with 8 gray times 3. Those are for cases we think there's more setup uncertainty. For example, the C-spine and the superior T-spine lesions. So RTOG define very clearly how to draw those target volume. So you should really let your attending follow these guidelines to draw their volume. And also the chord should be defined by, MR fusion or myelogram. So specific one thing is important is if you have an epidural lesion you want to include in the target volume, you have to make sure there is a 3 millimeter gap between the spinal cord and the edge of the epidural lesion. Otherwise, you cannot meet those coverage and meet the cord constraint. So the cord constraint is also very specific in the RTOG protocol. So you draw a partial spinal cord, so 5 or 6 millimeters beyond your target spine. That's called partial spinal cord. And you will have to also draw a conventional cord, which is 10 cm beyond your target spine on superior and inferior side. So the cord constraint has to be 10 gray maximum dose should cover less than or equal to 0.35 cc. And 10 gray should cover less than or equal to 10% of the partial spinal cord. And basically the maximum point dose should be less than 14 gray if you are doing 16 gray per fraction or 18 gray per fraction according to this protocol. So for spine cases, we find, of course, because you are trying to create a concave distribution, dose distribution. So IMIT or VMAT is required. At this point, we use 2 full rapid arcs or 2 partial rapid arcs to avoid shoulders or arms. One arc will be at collimated angle 0. The other will be collimated at 90. And before we had rapid arc, we use multiple fixed IMIT fields. And we don't find there's any need to do any non-coplanar beams because you don't have, most time you don't have clearance anyway. We follow the RTOG 0813 and RTOG 0915 long protocols requirement criteria for PTV coverage, high dose split, and dose fall-off. Again, our planner look at those 2 tables very carefully. So I just translated this. Maximum dose must be within PTV. Prescription isodose line, if prescription is 100%, maximum dose must be at least 111%, but not more than 167%. Prescription isodose surface coverage is PTV V100 should be 95%, and PTV 90% should be bigger than 99%. So let's look at the DVH. So the volume full dose should cover at least, should be covering 95% of PTV. 90% of prescription dose should cover more than 99% of PTV. And you got a cord constraint. Here, this cord dose is 9.33. So let's examine all these items item by item. Prescription isodose surface coverage. So for a prescription of 16 gray, 100%, PTV should be receiving at least, the prescription dose has to cover at least 95% of the PTV. So here it's more than 100% the dose cloud. You can see that we defined PTV V100 equal to 95%. So the second coverage criteria is 16 gray for V90% for PTV more than 99%. So here we get 90% prescription dose covering 100% PTV. So you have a 90%, you can see the whole 100% is covered. High dose bridge criteria. So maximum PTV dose is 135.3%, which is the global maximum, which is inside the PTV. That's one. Secondly, 105% cover the volumes outside the PTV should be less than 15% the volume of PTV. So here we have a PTV 19.1 cc. I got a V105 minus PTV 1.4 cc, which is 7.3%. So you can see my 105% mostly are inside the PTV. Very little is spilled outside the PTV. The conformality, prescription dose volume versus PTV volume. They will require less than 1.2. So here I got a ratio of 1.14, so which also meets. So basically your volume covered by prescription dose is less than 1.2 PTV volume. So the intermediate dose bridge, the R50 and the D2CM, for this volume of 19.1 cc, according to the protocol, you should be able to reach R50 less than 4.6, D2CM less than 52.7. What I got is I have R54, D2CM 43.6. You can see this is my PTV, and these magenta are the ring from 2cm to 3cm. So these V50 never touch the 2cm ring. So that's also meet. So the 25%, this is a dose crowd for 25%. So for this kind of case, the spine case, it's not desirable actually to do any non-copernabine, because if you do non-copernabine, it will kind of spill the dose out to the adjacent vertebra. So in case later on you want to do another SIS for the next vertebra or something. And besides, with our machine, with a very big gantry head, most of the time, after you kick a 5 degree, you will collide with the table. So there's no clearance anyway. And this is 12.5% distribution. So 12.5% for 60 gray is 2 gray. So it's very, so skin dose, everything is relatively low. So there are some people do rep doc, they always use just single arc collimator with 45 degree. Instead of we use 2 arcs, collimate 0, the other one collimate 90. There are a couple of, if you look at the distribution for the 100%, it's very similar. You can get very good coverage. 50% dose for is also pretty good. But there's a cost if you rotate the collimator 45 degree. Say, for example, if you rotate the collimator 45 degree, at least you will, the 5% of the prescription dose will cover additional 15 cc of volume. So you can see this spill out here versus if you have 2 arcs with 0 and 90 degree collimator angle. So this is the same thing, like if you are treating a prostate, people use 1 arc with 45 degree. 5% of the dose you usually don't deliver to those far away places. You are going to deliver it, for at least with the rapid arc. What's the reason? Because if you want to treat a rotation, a target with a rotation field, your jaw opening, if your collimate angle is 45 degrees, will be much larger as square root 2. And your opening area will be twice as much as when you compare two collimators at 0 or 90. So these leaves will certainly produce much more leakage dose in the superior and inferior. These parts should never be outside your jaw, usually. But now they are always under the leaf, which will produce leakage dose. And the other thing is the rapid arc at this point, they have unused leaf parked inside the jaw. It's different from the normal fixed MIT fields. Fixed MIT field, if you don't use this jaw, the jaw is parked, don't use these leaf, the leaf is parked outside the jaw. So, but these leaf, most of the time it's not going to be used because it's rotating in different direction. They are going to stay in here. And these leaves, they never close because they have a minimum leaf gap. Those actually can have plenty of dose. So that's the reason you create this kind of split, superior and inferior. So you have to be aware of that. So before we had rapid arc, we used multiple MIT fixed fields to create those spine SBRT plan. So you can actually use these fields, meet very similar constraints for the intermediate dose lift, but certainly they are not as pretty in terms of, because they have fingers, because you have only this many beam to use, and then you will have these, see, 25% you will get to the skin, and then 12.5% is kind of like fingers. So, but they can meet all the constraints. But commonly, I see lots of places, they do fixed MIT fields, with like 7 to 9, mostly posterior beams. So what we found is if you mostly only use posterior beams, often you will find it's harder to meet the R50 and DC 2cm constraints, if you want to use those constraints as your guideline. And we also find it's sometimes difficult to meet the 10 grade constraints, even though the maximum point dose can be met, like 14 grade can. Like, for example, you get the DVH of the cord, maximum dose for this one is pretty good, 12.4 gray, instead of, it's under 14. But the 10 gray actually covers 0.99 cc, and the 10 gray covers 11.9%. So this curve, instead of this kind of much lower kind of tail, it will be a little bit, so depends on whether you feel comfortable. You have to really push it a little bit to get that. Let's talk about the lung. So at this point, we have two protocols. We follow actually the RTOG 0618 for peripheral lesions, 3 fractions, 20 grade per fraction, and RTOG 0813 for 5 fractions with 10 grade per fraction for central lesions. For the lung, there are certain constraints for these 20 grade times 3. One of them is the ribs. So to prevent a rib fracture. The goal is 30 cc of chest wall volume should receive less than 30 gray. Think about 30 gray out of 60 gray. That is V50. So that's the 50% volume because it's 10 gray per fraction. For lung cases, it is often necessary to have non-coplanar beams to achieve fast dose fall-off. We now use 3 partial arc, rapid arc technique. Each arc at least 100 degrees, and non-coplanar couch angle up to 20 degrees. Our machine, because the head is very big, we find beyond the 20 degrees, very difficult to clear. So before we use the rapid arc, we use non-coplanar multiple field-in field or 3D CRT beam, conformal beams. So let me just go through, because this long lesion, peripheral lesion, has lateral kind of location. So for this case, it's a left lateral location and very posterior, close to the actual rib. The arc 1, I use gantry couch at 0, so you can go all the way to the back. So 170 to 30, and I kick the couch 15 degree. The arc 2 is a partial arc of from 330 to 110, because you cannot go too much posterior once the couch is kicked, otherwise you collide. And the inferior arc is couch kicked another 15 degrees the other way, and you counterclockwise going up, so 110 to 330. So let's go through those exercises of how to evaluate the plan again. So prescription isodose surface coverage, 20 gray times 20 gray is the prescription dose. PTV, 100% dose is covering defined as coverage 95% of volume. So 100%, I'm covering 95% of the PTV. The other criteria is 90% of prescription dose should cover more than 99% of PTV. Here I got 90% to cover 100% of PTV. So you can see this is a PTV and the 2 cm ring still again here. So the coverage is 100% here. High dose bridge. So I have maximum point dose 135%, which is the global maximum, which is inside the PTV. And the second criteria, 105% minus the PTV should be less than 15% volume. At this point, I get 0.2%, 105% outside the PTV. So it's very little splitge of 105% outside the PTV here. And the conformality, you have a prescription dose volume versus PTV volume. So the criteria is less than 1.2. So I get a 1.02. So it's pretty conformal here at above 100 here. And then intermediate dose split. This is actually the most difficult constraint to meet. So here at this point, the PTV is 40.2 cc. According to the protocol, R50 should be less than 4.2, and D2CM should be less than 59.6%. So you have this 2 cm ring here. You can actually touch this a little bit. So what I got is my R50 is 4.2, which is just to meet the criteria. And D2CM, I get 52.6, which beats this criteria. So at this point, the rib dose constraint is your V50, because you want a 30 gray less than, how many cc? So basically 30 gray is 10 gray per fraction. So if you don't meet these R50, very often you violate the rib dose constraint. So if you, so that's very important. The reason why, for me, the R50 is lots of times difficult to meet is because those fall off in 3D is very difficult if you don't have enough non-coplanar beams. Because I simply cannot kick the couch more than lots of times 15 degrees with colliding with the patient or colliding with the table. So, but if you try the best to get D2CM and R50 to meet the constraint, your rib dose constraint usually don't have problem. So here's the 25% dose distribution. It's basically mostly restricted in the ipsilateral lung because I'm only using ipsilateral arcs. I don't go through the other side of the patient to get to here. So this is the distribution, and 12.5% is also mostly restricted in the ipsilateral lung. So for central located lesion, we follow the RTOG 08313, which have more constraints because it's in the central location. So we are doing 10 gray times 5, and it includes the great vessels and some other constraints. We find that you can use the same technique, 3 partial arcs, just non-coplanar, 2 non-coplanar. Mostly you can meet those constraints without much problem. And for the liver, we have different protocols for mets, liver mets, 20 gray times 3 protocol and 10 gray times 5, depends on where the mets is located relative to this bile duct porta hepatus junction or so. And we also have a protocol for hepatocellular cancer, carcinoma with 5 fractions with 30 gray to 50 gray, depends on the V effective according to Laura Dawson's protocol. We find that from the treatment planning point of view, you have same kind of beam arrangement can work. So say, for example, liver case mostly located is right lateral. Then you can use 3 partial right lateral arcs to achieve your planning objective. And we still use those tables from the lung protocol. And these are the constraints I listed here for the meds. And we find actually the most difficult cases are the HCC protocols because there are so many constraints, all these different things happening. And but if you really try your hardest to meet the R50, these 2 cm, you actually will meet lots of these constraints without problem. But if your dose is spread out, those fall off is very shallow, lots of other problems, and the coverage will have problem too. So the task group TG101 provide lots of detailed information for SBRT implementation. So at this point, I just want to share some of our experience. So for SBRT spine, CT scan has to include the C1 so that vertebrae can be easily identified. And the setup uncertainty is large in this area because we have not figured out a better way to immobilize the patient because the flexibility in the neck area is there. And we find also fusion with MR in this area is very difficult because most times the patient is in a different neck position. So for this case, we add sometimes up to 3 mm margin for the PTV. And we prefer to use hypofractionation instead of the single fraction, unless that particular case we know we have pretty good clearance for the cord. And for this, we use a blue bag with vacuum suction and plus a head and neck mask as an immobilization device. For the SBRT T-spine case, the CT scan has to either include the C1 or L-spine so that it's very easy to identify which vertebra you're talking about. Because lots of these patients sometimes have multiple lesions in different vertebra, and you only are treating one or something that the physician thinks is problematic for the patient's pain or something. So you have to really make sure you are at the right vertebra. Mostly for these, we try to get patient arms on the side so that the patient can stay comfortable. And then, of course, your beams and arcs have to avoid arms. So use avoidance sector, and we also use the blue bag with vacuum. And the L-spine, of course, you have to include sacrum and lower T-spine. And the arms, we try to get on the chest so the patient can be more comfortable. For the lung CT scan, for upper thoracic regions, both arms, elbows should be over the patient's head and be included in the CT scan so that clearance of beams can be visualized during planning. Because if you don't scan the whole elbow in, and you created some non-coherent beam, you think it's really working, and then by the time you get on the machine, the elbow sticks out, you cannot even get clearance. So this basically has to be included in the CT scan, so you know, okay, whether you have trouble clear that. So all these cases have to scan at least 15 cm beyond field borders, because very often non-coherent beams are needed, and your calculation, you have to have more patients' information, and also for clearance issues too. For SBRT lung, liver, abdominal cases, 4D CT simulation must be done first to assess tumor motion range. Gating can only be considered only if motion is more than 5 millimeter and the patient has a regular, reproducible breathing pattern. Alternatively, an ITV can be created. For gating cases, you cannot really use the blue bag with the suction because you don't get the gating signal. So we sometimes use abdominal belt compression system, but many patients cannot tolerate that. So fiducials are necessary for liver and abdominal cases because there's no other way to visualize tumor, at least for the trilogy. Because lots of times, sometimes patient has lots of different surgical clips and have lots of artifacts, and CT image is not necessarily good quality, and lots of times all those tumors are very lateral. So you have a field of view problem on the machine to really visualize the anatomy. So if you don't have fiducials for lung cases, fluoro on the machine must be done before simulation to verify visualization of the tumor. So I'll go through that a little bit. So the other thing is if non-gating, may consider one or both arms on the side because non-coplanar beams could be used to compensate for lateral beams. But if gating is used, at least for trilogy, you cannot really kick the couch and still do gating. So only coplanar beam can be used for some machines. So arms on the side could further limit your beam arrangement. So VMAT, after we use the VMAT, we find it's a very good option. But for some machines, certainly you cannot combine the gating with the VMAT. Gating plus fixed beam MRT or enhanced dynamic wedge is not as advisable because it takes way too long to deliver. So if you want to use some 1 or 2 segments, use field in field instead if you must use it. Beam arrangement should always consider collision possibility. For lateral tumors, you have to keep beams, arcs on the ipsilateral side. So if no fiducials, you should create fluoro beams aperture that hugs the GTV to help you visualize and verify that your setup is correct. I'll show you an example. If there is fiducial, what we do is we contour the fiducial, create a fluoro beam aperture with fiducial as a corner. So when you do the fluoro, you know exactly where your fiducial should be and whether it matches. And combi CT alignment with the GTV, for those cases, bony landmark is secondary. You line up with the GTV instead of bony landmark. But it should be, the bony landmark should be agreeing with everything within a cm, because if you deviate too much, that means the patient is rotated wrong or something. You have to reset the patient up. Combeam CT sometimes will not align well with the average CT sim CT due to breathing variation. Also, combeam CT is pertained for all the phases. When you are gating, you only gate certain phases, so they don't really match. Fluoro to verify position after combeam CT before you treat. Fluoro between fields to monitor setup consistency. So let me go through. So invariant machine, you can, under the fluoro, only the MLC shape outlined. So we create a setup field in AP view with this shape hugs the GTV. So under the fluoro, you will see this red sign says gate closed. Green will gate open. The GTV will be visible on the screen with the throttle on. So our goal is for GTV to match MLC shape when beam is on. So you can see open gate, close gate, open. So when the throttle is on, you will see that our objective is to have the GTV hugging. See the green? GTV has to hug the shape when it's green. So at this point, if your cone beam CT, when you do the cone beam CT, okay, it's done under free breathing. Under free breathing, even if you have the fiducials, if you don't line up correctly, you will have trouble actually set up patient correctly. For example, if you most people get the expiration phase, and the cone beam CT is done for free breathing. So you should align the patient superiorly with the fiducial or with the GTV, not in the middle. So the superior position will represent actually the gated phase. So let's look at this example. This is after cone beam CT. Before we treat, we do throttle to verify. Make sure our beam, our setup is at the GTV. So take a look. Gate, open, and the patient's GTV is low. That's after cone beam CT. Everything we thought is lined up. But the therapist did not align superior part of this cone beam CT with gated CTCM tubes. So they did a middle one. So we decided after a couple of observations how much is off, and you can use your MLC as a ruler, because MLC is 5 millimeter, then you know how much is off. So after 5 millimeters, superior only shift. Take a look. Gate close, gate open. So your GTV is exactly hugging your designed place. So then you can also verify it at a different angle. This is oblique view. Gate closed, gate open. Gate open, so it's basically you give you confidence of you set up right. So from that time on, I always make sure the therapist align either fiducial or the GTV superiorly to the cone beam CT. Then you always get perfect. The bottom line for SBRT is at our institution, without an approved plan in the patient's chart, no treatment verification can be done. A dry run is necessary. Physics must be present for treatment verification. If there's IMRT involved, without IMRT QA documented, no first treatment should be done. And attending must be present for every treatment fraction. Physics should be available for every treatment. So what is a dry run? It's a treatment verification. So it's not only should check whether you can reproduce the setup, you can have to verify your isocenter, whether you actually, for example, can get to that GTV in the lung. You have to clinically mold up each treatment field. So therapist has to be in their clinical mode, physically actually mold up each field in the console. Because that is the only way you can check every single beam clearance collision. Whether there's a collision, whether there's issues, and you can check any interlock come up in the clinical mode. So if you don't run it in the clinical mode, you think everything's fine, but it could run into problem when they run it in the clinical mode, because clinical mode for the machine is the most sensitive, they check the most, so that part you cannot skip. And we actually discovered lots of things during this process. So if you have somehow MLC interlock, when you mold up a particular field, MLC interlock, then you have to reinitialize MLC But if you still cannot clear, means you have a corrupt MLC file. So it's become, basically this beam is not going to be deliverable. Okay, can you imagine if you only have two arcs, one arc delivered, the other arc cannot be delivered? So there's also potential like MU problems. For example, if you put more than 1,000 MU in your field, for any single field beyond the machine capability for non-SIS beams, in clinical mode, they will simply don't let you mode up. So clinical mode up each field is essential in the dry run. And after your dry run, also during the dry run, you can also discover the patient's condition. Because a lot of times the patient will say, I cannot handle this, it's too long, or something. But treatment is going to be as long. So the doctor actually can decide, okay, before the treatment next time, I will give the patient some medication to help them relax or do something. Because these are the process you can discover beforehand any potential issues, whether related to the patient, related to your technique. So it's very important. We don't skip this. In summary, the RTOG protocols are useful guidelines, very useful guidelines, actually, for treatment planning for SBRT. And we find now the planners will use these guidelines to make sure their plan fit those. And when I check the plan, I also open up those guidelines to see whether every single part is met. The SBRT procedures, from CT simulation to treatment planning to treatment verification and treatment, warrant serious attention from everyone involved. So serious attention means you don't make assumptions. Because sometimes the therapist, oh, this is clear. How do you know it's clear? And lots of times they make assumptions, and sometimes they tell you it's not clear. Oh, why is not clear? Oh, I cannot rotate to that side. But I'm not doing rotation to that side. I'm only doing partial arc. So you really have to still into them this clinical mode up. The dry run has to be a clinical mode up. You have to make sure your plan can be carried out without problem. And also, attending, when they select patients, they really should follow ASTRO's guideline about what kind of patient is suitable for SBRT. You cannot really have a patient in general very, very kind of bad physical situation. They cannot tolerate such a long process. So that is also the time you find out the patient's condition during the dry run. And we find, okay, establishing clear protocols for your own institution is necessary for the safety delivery of SBRT. So even though at this point we're participating in the RTOG trial for 0631 for spine, but even though we're not participating for the lung protocol or the liver protocol, you can actually use this protocol, establish your own protocol, just make sure your institution, everybody is trying to follow this protocol. So because these are very serious procedures, so anything goes wrong, it's potentially a reportable event or misadministration. So that has to be put everybody into a serious kind of mode to deal with these kind of procedures. So I want to acknowledge my physics colleagues, including dosimetrists and all my physicians in our institution. Thank you very much. If you have any questions, I can have, I don't know.
I have one question for you. The RTOG protocols also insist that the minimum field size should be 3.5 by 3.5 for lung protocols. Mm-hmm. How do you handle that in VMAT cases where you have no control over it? Basically, the MLC could have any peculiar shape, definitely very less than that.
No, actually, if you set, that's why another important thing for rapid arc is make sure your isocenter has to be placed in the middle of the tumor. If you have that, you don't have a problem with jaws. But if you place your isocenter not in the center, just like a lollipop, you rotate it, it's very little change for the jaw. It's very small jaw. But if you put your things outside, so rotate this way, then the jaw is very big.
No, I'm not worried about the jaw size. I'm worried about the MLCs, which may basically create shapes which are much more smaller than that. You can have jaws as much
as... If you have multiple non-coherent beams, you don't have this problem.
Can I ask a question?
Yes.
First of all, I want to thank you. I think that was a very educational presentation.
Thank you.
And I know for myself, first time planning SBRTs, it's a little overwhelming, because it's a high risk, high reward scenario. You miss that tumor, plan something wrong, it's going to be pretty bad. And I agree. I think the protocols give a lot of good guidance. So I want to make one comment that I have at University of Virginia, we did a spreadsheet that kind of automates some of the calculations of some of those parameters like high dose spillage and low dose spillage, and looks up from the tables for you. And so if anyone would like that, I'll be sitting in the back. I'm happy to share it with you. Our dosimetrists use it to evaluate plans on an incremental level and help them kind of get the best plan we can. So that's a shameless plug. Also, I had a question for you. When you were planning for your lung SBRT doses, were you using heterogeneity correction?
Yeah, we are using heterogeneity correction. We use the AAA algorithm, Eclipse. Yeah.
My question is, with the 0618 protocol, they pretty clearly specify that you're supposed to calculate the dose with everything being water equivalent. And so I didn't know how that dosing, 20 gray times 3, when they were intended it to be calculated with water density, would be different than what the 0915 protocol specifies for, say, the fractionated 12 gray times 4, where they specify you have to use heterogeneity corrections. And so I'm not sure how comparable the practice of calculating the 0618 doses with heterogeneity corrections would be. So I didn't know if you wanted to comment on that.
That I think this, because we've been using long dose correction for like as long as I remember, we used the Eclipse AAA algorithm. So at this point, I think lots of times if you use some algorithm like pencil beam algorithm, they definitely specifically have some requirements, or they don't even allow you to do those kind of patients with those kind of those calculation algorithm. But we have not actually, we are not enrolling those patients into those protocols. But at this point, we are not really trying to change our dose calculation algorithm simply because these lesions are small. It's just we did not really. See, lots of times I find that because we are not really enrolling all these protocols to enrolling patients to those protocols because we simply don't have the manpower to, to deal with all these enrollment. But my point is, you try to follow as much as possible, so that way you know what you are doing is at least safe. Mm-hmm. Maybe not exactly what the protocol requires.
No, I agree. We were treating kind of according to protocol as well, not accruing, and so we were just following the constraints, kind of using as guidelines. Even though we were adding an extra fraction, we were doing 5 times 12. But I'm just not sure how a 12 gray per fraction would compare to a 20 gray per fraction when you're talking about calculated with and without heterogeneity. So just a comment kind of, for thought. So.
Yeah, I think so. Also, those fractionations, there are so many different fractionations. So what I think is what we are doing at this point is try to stick with something we are comfortable with. This is what we are going to do, even though maybe there are lots of different protocols like 12 gray times 4, like sometimes 8 times 3, sometimes like 20 times 3. So it's just very hard for us to adapt to every single protocol. So we try to also like 10 times 5. So all these, I'm not even sure, which one is the best one. Since we are not enrolling patients to those protocols, we just stick to what we feel comfortable with.
Great, thank you.
Yes, I have a question. I'm wondering if you have any concerns about the interplay effect of the MLC motion and target motion using VMAT or using RapidArt for lung SBRT.
Yeah, actually, we had done a study. It's published. My colleague published a paper in the physics in medicine and biology, and he did a 2-patient study with VMAT. Actually, you don't have that much interplay, like this dynamic multi-leaf MRT fields, because you tend to have the leaf are not moving only one direction, and also it's from multiple angles during this whole rotation. So the conclusion at this point is much less a concern. And besides, these SBRT fields have a lot of MUs to deliver. So it's not that fast. So you can go through multiple breathing cycles to go through them.
Thank you.
Thank you.
Yeah, excuse me. Just for clarification, when you were showing the fluoro, were you gating or just?
Actually, you can only show the aperture on the barrier machine during the gating. If you are not gating, they don't show you. Which is okay.
So that's, yeah, because I'm not familiar with that kind of application. So the moment you were holding, it was a gating treatment. Is that what it was?
This long case is a gating treatment. Yeah.
Thank you. Thank you.
I was wondering if you worry about interleaf leakage for 0-degree collimator angle for rapid arc plans, and if you take into account like couch attenuation for particularly for the SBRT spine treatments.
Yeah, we actually just do the variant, standard this couch. They attach the couch structure, and you calculate the code based on that. But honestly, we never really did a vigorous study saying how accurate the couch structure is. Representing the real attenuation, but we definitely fix the bar position for every patient, so we don't like move around the bar. So as far as, because it's rapid arc, lots of times, very rarely you will have one beam stay long time in one direction, going through the like a very thick part of the supporting bar or the table or something. So we don't find that's a big problem. Thank you. Sorry.